Hello, and welcome to Remembering Together, the LMJ's podcast. I'm your host, Matt Harold. Each month, we explore the many ways Alzheimer's and other forms of dementia touch our lives, from personal stories of families affected by this disease to the ongoing efforts to find a cure. Join us as we raise awareness, share support, and learn together about the impact of Alzheimer's on nearly 7 million people worldwide. Let's remember together and work toward a future where no one faces this disease alone. Welcome to Remembering Together, an LMJ's podcast. Today is episode number 7. I didn't know we were going to make it this far, but here we are, and I'm proud to say that I'm going to do as little talking as possible because we truly have an expert here with us today. We have someone here today that I'm confident, no offense to my previous guest, is the smartest person that we have ever had on this podcast, and far and away, way more intelligent than I am. So we have someone who attended Washington University in St. Louis for both their undergraduate and medical school. Today with us today is Dr. Gitelman. Dr. Darren Gitelman is a behavioral neurologist, and I'm going to read this because there's a lot of good information. He serves as a director of cognitive disorders for the Advocate Medical Group, Illinois, the Neuroscience Service Line, Midwest region, he is a medical research director and the senior medical director of Advocate Memory Center. He is also an adjunct clinical professor of medicine at the Chicago Medical School at the Rosalind Franklin University of Medicine and Science, and an adjunct lecturer of neurology at the Feinberg School of Medicine at Northwestern University. Without further ado, Dr. Gitelman, thanks for being here with us.
Thank you for having me, Matt. It's great to be here. Thanks for the very kind introduction. We'll see how I do on the podcast.
The intro is just as important. Now we're going to prove whether or not all the things I read.
Your listeners will be the judge.
Exactly, 100%. So, Dr. Gitelman, really, really happy to have you here. Thank you for taking time to be with us. We do a lot of work with you, and want to kind of let you start the floor. I told you a little bit about the current person. Tell us just a little bit about yourself, kind of your story, and how we're here today.
So, as you said, I'm the senior medical director for the Advocate Memory Center. I've been with Advocate now about a little less than 10 and a half years. Really remarkable. It's been great. We've been able to develop a memory center there, and started out with myself, a nurse coordinator, and a social worker, 3 people.
Okay.
And now there are like 28 people working there in research and in clinical care and in education. So it's been a remarkable journey.
Wow. And obviously the journey's taken you. So kind of I learned a little bit as we were talking before we started the podcast, but to tell our listeners kind of how we got here. Grew up not in Illinois and not in this area. I'd love to hear about that.
Brooklyn, right? So grew up in Brooklyn and went to Washington University in St. Louis. They had an 8-year medical program. So it was like sort of a standard length medical program. Some of them were 6 years, but I thought we'd get that college experience in. Did the 8-year program, finished up at Washington University in St. Louis. Met my wife there. Then we both journeyed after that to New York, did a residency there at what used to be called the Columbia Presbyterian Medical Center up in 168th Street. I remember my wife and I drove in there late at night when we were just coming to look at the program, and a little scary up in northern Manhattan. Our house was in Riverdale. And went to, did my internal medicine residency at Columbia Presbyterian. Finished the internal medicine residency and did a year of fellowship in brain imaging. Then went up to the Massachusetts General Hospital in Boston, where I was resident and chief resident in neurology. After that, to the Beth Israel Hospital, and then did a fellowship in behavioral neurology. The brain, I thought, being the most fascinating part of neurology. After that, then came to Chicago, was at Northwestern University Feinberg School of Medicine until 2014, from 1994 till 2014, and then recruited to Advocate.
Wow. So kind of answered it. Brain's most interesting part is your opinion on that.
They're the nerves and the arms and legs, but I thought, well, we'll stick with the brain.
So I'm going to go back a little bit and ask you, did you always want to be a doctor? Was this the plan from an early time? And then obviously you decided to go into neurology, but what was the plan? How'd you get to here for listeners that might want to take the same career path as you?
Yeah, so my mother said you could do anything you want in your spare time as long as you're a doctor. Typical Jewish mother upbringing. No, she was marvelous. And yeah, I think from an early age, I think I wanted to be a neurosurgeon at first. But at the time, I thought they have to get up very early. So the neurologist could get up later. So I would be a neurologist. Now I wake up at 5 a.m. every day. So I'm getting up early.
Life has changed, but you didn't realize it at that point. So obviously you're here to talk about, unfortunately, some things that are not very happy thoughts and happy feelings that people have. So obviously want you to educate our listeners when it comes to Alzheimer's and dementia. Kind of want to start with, if you want to, high level, what it means. Obviously, dementia's at the top, and kind of go from there. If you could give our audience a little bit of information what different forms of dementia and Alzheimer's for our audience.
Yeah, so I'll say when I was starting out, just to kind of take it back a little bit, just very interested in the brain and brain behavior correlations. How is it that the brain generates our behavior? And that's what generated my interest in behavioral neurology. And for many years, I did functional brain imaging. So this started off with PET scans, where you could image someone and then see what part of the brain lit up on the PET scan. And as I was coming out of my fellowship, the functional MRI was invented, basically. So they had the MRI scans, but they figured out a way to rapidly image the brain using MRI, where you didn't have to give someone radiation, and then could learn what part of the brain lit up. And so I started off in that in '94, really when the field had started. And myself and a physicist at Northwestern helped to bring this technique to Northwestern. It's grown far beyond me, obviously. And then for many years did functional and structural brain imaging to learn more about how the brain changed with disease. And we studied dementia. We studied a number of other disorders as well. And then when I came to Advocate, was interested in, we just didn't have that same technology at that point because it's not an academic medical center. And so then changed to doing clinical trials. So I've always cared for patients who have brain disorders and have done that now for 30, 31 years or so. A lot of it being patients who have various forms of dementia. Earlier on in my career, did maybe more with other disorders that affect the brain, ADHD and disorders like that. But really for the last 10, 20 years or so, have focused more on patients with dementia in its varied forms, how it affects the brain differently. You can have a disorder like Alzheimer's disease, which often affects memory, but then in some people it affects language. And my mentor at Northwestern, Dr. Meslam, was one of the first to describe a disorder called progressive aphasia, where the pathology that affects the brain, instead of, let's say, affecting it in the memory centers, may affect it in the language center. So we learned a lot about that. Or when it affects the perceptual center, so you have trouble with visual perception, even though it may be Alzheimer's disease. In terms of the disorders, as you made that sort of umbrella motion. So dementia is the umbrella in the sense that it's a general description of someone who is having difficulties with their thinking and is starting to be or is significantly impaired in their independence in their daily living activities. And if I showed you a list, there'd be 100 things that can cause that. Everything from strokes to disorders like Alzheimer's disease to infections such as HIV and syphilis and so on, to other disorders of metabolism of the brain and so on, or inflammatory disorders. The degenerative dementias like Alzheimer's disease are just the most common causes in older adults. So dementia being the umbrella, and then we have all the different causes of dementia. When I see a patient, our job is to obviously speak with the patient, get their history, examine them, and then try to understand, what the cause is of their cognitive impairment. Are they at the point of dementia? Are they likely to get dementia? And then what tests would we get on them? And then how is it best to approach and treat that?
Very it's just there's so many layers of what you're saying, and the general public, has some different, has not anywhere near the knowledge that you've experienced over the last 35 plus years at this point there. But obviously know that passion about what you do, and in that passion, know that you have obviously a huge part of your daily work life with having personal impacts. You want to talk about a little bit about any personal impact you've had with Alzheimer's or dementia?
Yes, my family, and I don't think we knew what the diagnosis was at the time. And that's been really, I'll say from a professional point of view, it's been so remarkable how well we can make a diagnosis now that we really couldn't. And it's really different from when I was a medical student. When I was a medical student, there was senile dementia, there was pre-senile dementia, so senile older than 65, pre-senile younger. And Alzheimer's was taught us as really a small portion of that. And now, we understand, how much of an impact Alzheimer's really has. When I was in medical school, you could make the diagnosis, but only post-mortem, right, or autopsy. And you could guess that a person had Alzheimer's, but you wouldn't know until you saw them, until they had an autopsy. And nowadays, you can have a blood test that can give you that result. Personally, in my family, there were several of my grandparents had brain disorders, not all of which we really knew what they were. My mother's father died in his 50s of a rapidly progressive brain disorder, really don't know what that was. My father's parents, my paternal grandfather may have had Parkinson's disease or a Lewy body type of dementia. Again, it really wasn't diagnosed at the time. And this was, in the 1980s or so, we couldn't make that diagnosis in life. And my father's mother had probably some combination of vascular and Alzheimer's disease. So, we knew about that at the time, but just didn't really know what they had. They didn't have, Aricept and Episil. Then they didn't have any of the medicines now. They certainly didn't have any of the antibodies available. There were some medicines that supposedly increased blood flow to the brain, like Hydergine, but didn't really work at all, weren't really well tested. And, people developed these disorders and they would just progress and pass away. Nobody really knew what was going on. So I guess maybe that was part of it. And, but a lot of it just trying to understand what's happening to the brain and understand how we can help people.
Crazy when you talk in terms of years and timeline, like that 45, 50 years ago, this was, where we are today. And so I'll speak for a large segment of people because of people like yourself and the work that you guys are doing to make this way more prevalent and what's possible, even as 10 years ago, which is possible today, is truly impressive. So the work I can't, thank you, people like you enough, and someone like you, and you're here today, so I'll thank you. But most importantly, what you guys are doing to really, make a difference, and we all know what that true difference that we want all this to come to be is to find a cure. And obviously there's a lot of work that's being done to make that happen, but it's not going to happen immediately. But when you talk about 1985, and that's not that, it's long ago, but it's not that long ago. So that's sad to know that that's what was going on at that time. And so thank you for that. So as we dig a little bit deeper, I know you hear this, what's considered in my family member, what's normal, what's not normal when it comes to, if I have concerns with a family member, kind of go through, not a full-on study of what you do with a patient, but just high level to kind of help, people understand, and a little education on what's normal of aging and what's potentially abnormal that could be a cause for concern.
We all experience some lapses in words. We all will occasionally misplace things in our home or forget a bill, or I don't know, you have to go search for the car in the parking lot and that. But fundamentally, it doesn't really interfere with daily life. It's not repeated. You might happen once a year, or something like that. And some people are more forgetful than others or may misplace things more, but that's who they are, right? But when it starts to be more prominent or really starts to interfere with daily life, that's when we start to think there's a real problem. The Alzheimer's Association has a nice sort of 10 list. I don't remember the whole list in front of me, but of 10 warning signs.
Right.
But it all turns out to be sort of memory loss that interferes with daily life, word finding that interrupts your communication, difficulty with navigating and getting lost, misplacing things consistently. So it's all these types of problems. But the sort of operative idea is that they're consistent. They begin to occur consistently.
The frequency standpoint of it, right?
And they
absolutely.
begin to really interfere. So your spouse tells you something, and then 5 minutes later you ask the same question again, and then 5 minutes after that you ask the same question again. So that's just not the way it should be. So if the symptoms are consistent, repeated, and particularly if they begin to interfere with what you can do, it's weird with these disorders is that they also fundamentally interfere with a person's own ability to tell how much trouble they're having. And so unlike cancer or heart disease or other, diabetes and other disorders where the individual knows what's happening to them or can feel it, the individual often with dementia, not all the time, many people know, but many of people will say, they're fine, or, they didn't know the date, but they're retired, so why would they know that? Or
covering it up almost, right?
You're right, but they're not voluntarily covering it up. They're covering it up because their mind is not remembering the incident. And so, often in these, when people with early Alzheimer's or early, cognitive disorders, they just won't notice that this is happening to them, and that's why we rely so much on the partner that comes with them as well in taking that history.
I always go back to, from my mom's experience, who she passed from early onset Alzheimer's, there was only one time in the whole progress that she made, a bold statement of, you don't know what it's like to be losing your mind.
Right.
And that was the only time in the whole process because there was so much, just as to your point of all the other diseases that are more body related than brain related. It's the effect that the family has because their loved one does really necessarily know what's going on. And that's really, really the worst part of the experience for the family because it's terrible for the person because if they knew what they don't know, they'd feel even worse, but it's what the family is feeling, that helplessness of, there. So, but.
Yeah, and it's hard when you're seeing people in the office, so, you listen to the patient, you listen to the family, but sometimes the patient sort of has one view, oh, this has been going on a few months or there's just a few lapses, and then the family, you try to sort of sensitively ask, what do you notice? Is that any different? Or I always say to the patient, can I ask your, daughter or son or wife or what's going on? They may have a different opinion than you because, then the family be like, well, they didn't remember this and they lost the car and they haven't paid the bills. And the patient sometimes is just, stunned or sometimes denies it or, just a lot of times just not sure what's going on.
So neurologist / counselor / there's got it. That's the toughest part. I just can only imagine all you're trying to do is help somebody, but they don't even know that, they might need to be helped. And, to hear it that way it's tough.
It is very hard. And it's hard on the family because, families come in, they want to help their loved one, but they also don't want them embarrassed. Right? They don't want them to feel, put down or embarrassed or deficient in some way. And so you have to try to get that information while at the same time validating that person or, just trying to, come out in a way that's helpful to them.
Absolutely. Yeah. No. Obviously, I took a nice note. When this all started at Advocate, there was 3 of you. Mm-hmm. We're up to 28. Part of the work that LMJ's does, and I'll pub myself a little bit here. When this whole nonprofit started, to me it was, we're doing this. I want to partner with someone who wants to help us find a cure, or who's trying to find a cure. That's where, I'm a solutions-based human. So when we started talking with Advocate, very, very exciting. So love for you to talk about what Advocate's doing with the Memory Center and, and obviously integrate what we have supported with you guys and why we're doing it with all that's going on inside Advocate for memory there.
Yeah, thanks. So LMJ has been great, and all of our supporters. We are supported by philanthropy, yours and others, which has really made a difference. It's hard to support. The medical system in the U.S. is so complicated, but I will say it can be.
We're not going there, but yes, I got you.
Really hard to support memory centers. We don't have procedures, and things like that. So it's tough, and it's a labor of love. And a shout out to my colleagues at the Memory Center, Dr. McCormick, our nurse practitioners, Margaret, Anna, our social worker, Danielle, and neuropsychologist, Liz Hartman, and all the people, who support us. It's really a labor of love, to go into this and take care of the patients because, we see people who are older, we see people who are younger, and it can be very, very tough on families. Yeah.
Tell us about the Memory Center. What
Right.
exactly? Let's hear about that.
So we started out and wanted to be involved because I think you can care for the patient, but being involved with the research and developing new methods of treatment, methods of diagnosis, I think is really important to the field. So I really always wanted to do that. So we've been involved in clinical trials from the beginning, and that's sort of our main research focus. So clinical trials have been everything from industry-sponsored trials. So we've been involved with all the major, these new what they call monoclonal antibodies or anti-amyloid antibodies, aducanumab, lecanemab, donanemab, and so on. So we've been involved in those clinical trials.
You're losing me, but I'm listening.
Yeah.
That's why you're here.
New treatments, new disease-modifying treatments.
Dumbifying it. There we go. New treatments. I got you now. We're back. See? Yeah. Love it. No, good.
But also, we have been involved. And these are treatments for people with what's called the sporadic or non-genetic forms of Alzheimer's disease. What we commonly think of the older patients with Alzheimer's, but sometimes affecting people in their 60s or younger. But we've also been involved with clinical trials for people with genetic or dominant forms of Alzheimer's disease. Those patients, if they live long enough, and long enough can mean into their 40s, so are going to get Alzheimer's disease, 40s, 50s, sometimes 60s.
When you say genetic, are those people who have taken the testing to know that they have?
Little different.
Okay.
Yeah, so there's a gene called the ApoE gene. It comes in 3 types, 2, 3, and 4. And if you have the type 4, so everybody has 2 copies of every gene, right? Half from your mom, half from your dad. So you can have a 2 and a 2, a 2 and a 3, 2 and a 4, and so on, all those combinations. Yeah. If you have any of the 4s or 2 of the 4s, you have a greater risk of developing Alzheimer's disease. You might not get it, but you have that risk there. Just like you could inherit from your parents the risk for heart disease, right? And you could treat that now, right? You can be on a statin or a medication for your hypertension or diabetes and may not develop heart attacks, but you have that risk. Same thing here. So you have that risk of developing Alzheimer's disease, and you're more likely to develop it at a younger age than someone who doesn't have the gene. Gotcha. But even if you don't have the 4 gene, you can still develop Alzheimer's disease because there are so many other genes involved, and we don't fully know how they interact and cause the disorder. So 60% of the people don't have that 4 gene, but they still develop Alzheimer's. 40% have that 4 gene, and they're more likely to develop it. And that's the bulk of Alzheimer's. So 95% of Alzheimer's disease is this sporadic type of Alzheimer's that may or may not have this ApoE4 gene. And people, when 23andMe was around, you could get your Ancestry.com, you could get your testing for your ancestry, and they would do the Alzheimer's gene, and they would test for this 4 gene and tell you whether you were at risk. But about 5% or less of Alzheimer's are a dominant genetic form of the disease. And those people, it's not a risk anymore. 99.9% of the people with these types of genes, just 1 copy of the gene, are going to get Alzheimer's disease, if they live beyond their 40s. So they're really desperate. These are really young people, young families, really desperate. And so a population where if you can make a difference not only is it huge for them because they're so young, but it's huge for everyone else, because if you understand those genes better, maybe you'd understand more about what's causing a disease. So we're involved with that. That's called the DIAN, Dominantly Inherited Alzheimer's Network, and Trials Unit. So Dominantly Inherited Alzheimer's Network Trials Unit. And we've been involved for a number of years now with their clinical trials. It's an interesting group because since you know they have the gene, there's some way you can, in a sense, predict when their onset of Alzheimer's is likely to be based on their family history. So now there are trials that are looking at treating people everywhere from 10 years before to just after the diagnosis. So they have some of the pathology, but they might not be so advanced yet. But now there are trials, what's called the primary prevention trial, where they're going to get this disease. They have the gene, but you're so far in advance, 11 to 25 years before diagnosis, that you can look at, can we actually prevent the pathology from forming and then, make a difference later on. So that trial starts. Unfortunately, current difficulties in NIH and political climate has potentially cut off funding for some of that. So this is so important. So any of your listeners who are involved with advocacy, really important issue that funding is in jeopardy for studying this disorder. The other types of research we've been involved in are prevention trials. So we now know, so every few years there's a commission called the Lancet Commission. And the Lancet Commission has come out in 2017, 2020, 2024 with lists of factors that may be a risk for dementia. So in 2017, things like hearing loss and your education and whether you're depressed or exercising. So all those factors came out. I think at the time there were 10 factors, and they accounted for 35% of the risk for developing dementia. 2020, they added a couple more factors. Now accounts for 40% of the risk of developing dementia. 2024, two more factors, 45% of the risk of developing dementia. So there are now these trials that have taken place looking at if you deal with some of the factors, can you reduce the risk whether someone will eventually develop dementia? So if you pass away from something else, you get into your 80s, you have your heart disease or whatever, and you pass away and you don't have dementia, you win, right? You don't have Alzheimer's disease. So we, in 2015, there was a trial called the FINGER trial, landmark trial, Dr. Kivipelto from Finland. And it looked at various lifestyle factors, exercise, diet, whatever they eat in Finland, and social interactions, brain training, and so on. And they already, they have nationalized healthcare there, so everybody gets great healthcare, but this was a step above that. And they showed that people after 2 years did better in terms of cognitive testing. They were faster, their memory was better, their executive functions were better, and they were less likely to develop other chronic diseases just by following this program. And so this is now a worldwide effort. There are these FINGER trials, U.S., China, and South America, throughout Singapore. And in the U.S., this trial is called the U.S. Pointer Trial. It's been heavily supported by the Alzheimer's Association, which is amazing, huge trial, 2,000 people around the U.S., 5 kind of regions, each region recruiting 400 people. The main site was our cousins at Wake Forest Hospital now, part of Atrium and Advocate. Then in Chicago, Rush and us were sites for it. Up in Rhode Island, Brown University, Houston, and then out in California, in Davis, California. So 400 people recruited, and people could either they were either kind of programmed to do the exercise and diet and so on, or they were allowed to kind of self-guide themselves. And we're going to see the program people may be a little more consistent than the self-guided, and we'll see if there's a difference. That the top-line results, the main results, are coming out at the Alzheimer's Association International Conference in July. So here we are, we're involved with trials, industry trials, we're involved with genetic trials, And then we're involved with preventative trials to try to reduce the risk. Now we're in a trial called the preventable trial. For older adults, they'll be given a statin or placebo and seeing does that prevent, because statins have an effect on cholesterol, but also effects on inflammatory markers as well. Can that prevent or reduce or lengthen the time to which you might develop dementia? So research has been important. Other areas we've been involved with one of the new blood tests for Alzheimer's disease. So we're one of the trial sites for the development of these new blood tests. Our own social worker has done work on art therapy. Art therapy in Alzheimer's disease. Does that help? What she looked at is not, I wish painting something would prevent Alzheimer's, but this was really interestingly a communication trial. So does doing that artwork for the caregiver, for the patient, does it help them communicate better? And it, in fact, it seemed to have a little more effect on the caregiver than the patient, but that's so important, that communication. So we've been doing this work in this research work now for many years. We also do educational work. I think that's, educating the community and educating our colleagues. I don't know if you know that Illinois, in the recent, maybe in the past 2 or 3 years or so, the law passed that all adult physicians have to have at least an hour of dementia training, by their license renewal. So we've done some of that education as well. I think that's huge. Yeah.
Right. Obviously they can't make any diagnosis, but it's that, what are you looking for?
Just to be aware.
Awareness is huge. Absolutely.
Right. When you show up in the ER and that person's not cooperative or confused, and so you're not going to make that, you're not going to diagnose dementia in the ER, but you got to be aware of it. If you're a surgeon operating on a patient, your patient's confused afterwards, what's that all about? Or just even thinking about the fact as an older individual, they might develop a problem with the surgery. What's the right way to do the anesthesia for them?
Right.
And so on. So I think that awareness is so important.
Obviously, you deal with this every day of your life. Best piece of advice you could give to somebody who has no thought about being concerned with Alzheimer's, but best piece of advice to live your life as best as possible. I know that's a very generic question, but obviously you deal with patients all the time. What can you say?
So I don't know that I follow the advice. So
that's right. The best advice is
I don't sleep enough. So
but I don't eat well. I don't sleep enough. Yes, I get it. No, there.
So we all have it. So there are these factors. So exercise is huge, and I'll get back to that. A healthy diet, which will, so I'll just kind of bring the fact and we'll go back to
absolutely.
them. So exercise, healthy diet, sleep is important. Connections, so social connections, so important. I think keeping your mind engaged, and we'll talk about what that means. And then sensory input, right? So hearing, huge. Hearing contributed out of that 45%, about 8% to the risk for dementia, which is unbelievable. Wow. And, eyeglasses are easy. There are no batteries, right? It's easy,
right. True.
Right? The hearing aid, it's got batteries, you got to charge it, you got to replace them. They're fussing, there's little dials on them. They fit in the, so if you want to look good, they fit all the way in the ear, but then they're teensy tiny, right? And, you got to manipulate that thing. You got to remember to put it on.
Right.
And even the most, hearing aids are very sophisticated now. They have, they can amplify by frequency and so on.
Bluetooth technology.
Right. It's all right. My mother, it hooks up to the phone.
Right.
Right. But you have, but it's not seamless. You got to switch it. Or if we're having this conversation, you can see my lips, which actually makes a difference for understanding. And but if you are in a restaurant setting where there's huge amount of noise, 6 people around the table, each of them contributing to the conversation, it's still very difficult.
Right.
Yeah. So your brain has to do a lot of processing of this auditory and visual input. And so if it's degraded in some way, degraded because of hearing loss, degraded because your cataracts or your macular degeneration, your brain just doesn't get the good information it needs to make those decisions, or to, we've all seen an older person at the table or someone with hearing loss, and then They're nodding along. And then you ask them later, like, I don't know what they were saying, no clue. But, so.
Trying to fit in, right?
Right,
Yeah,
right, fit in. So, we encourage all our patients, hearing, get that checked, get the hearing aid if you need the hearing aid. A lot of people, some of it's vanity because they don't want to look old, because you look older if you're not participating in the conversation. Right. So you look young and engaged if you're having the conversation,
right.
no matter how gray your hair is.
Right.
Mine's pretty gray. So
I don't have much of it, so I'm right there with you.
Yeah, or your vision. So all of those are important. So exercise, in order to sort of follow the guidelines, it really should be moderate exercise, which means you need to exercise and it causes you to breathe heavier and sweat, right? So a moderate level. Always, anyone listening to the podcast, don't go out and train for the marathon. Talk to your doctor first. Make sure the exercise program is good. Don't go out and run a mile if you're not doing exercise. Don't go all out because you'll hurt the next day, and then that'll be the end of the exercise. Take it really slow, build up, but take weeks to build up. Take months to build up, but eventually build that up as long as your body can take it and you're doing something that's not going to injure you. You don't want to get injured.
Totally.
You do have to push yourself a little bit. Diet, Mediterranean diet, something called the DASH diet, which is a hypertension type of diet. Rush came up with a fusion of this Mediterranean and DASH diet they called the MIND diet. So it focuses more on brain-healthy foods. So instead of just fruit, it can be good, berries are supposed to be, a better type of fruit, I suppose, than nectarines or something.
Okay.
So, it focused on that, and those diets seemingly are beneficial, and there are clinical trials of that. Obviously, getting your sleep, 7 to 8 hours of sleep a night. If you have sleep apnea, try to get the sleep apnea treated. Nobody loves the mask. Although some people, patients, a friend of mine uses the mask. They use it every night. I guess they don't love it, but they love the fact that when they use the mask, they are not dead tired the next day, and their oxygen measured at night is not less than it should be. So they're getting the oxygen they need. So treat the sleep disorders if you can. Avoid certain medications that have bad side effects. So there are some medications that have a property called the anticholinergic property. So Benadryl has that property. Some of the which is a first-generation antihistamine. Second-generation antihistamines like cetirizine or fexofenadine or so on, they don't have that. They don't have as much of that property. But the early chlortrimeton, Benadryl, and drugs like that. Some of the drugs for dizziness have this anticholinergic property. Some of the drugs for your prostate when you need to go to the bathroom and try not to go so often, oxybutynin, they have that property. Not good for older brains. And so watch what your medications are. So we've talked about exercise, diet, sleep, medications, sensory input, social connections, really important. A lot of older individuals are very isolated. Maybe they have family. Maybe the family's not around here, so they're not connected with them. They're not going over to the kids' houses. Or, you get old enough, your friends pass, and how are you going to make those connections again?
Right.
But the social connection's so important for keeping people not engaged, not depressed. And then, mental engagement. So it doesn't just mean doing a crossword or Sudoku. It means doing whatever your mind finds challenging. So I know my dad used to, do solitaire, but he'd do the same solitaire game 100 times in a day. So maybe it was challenging the first time, but it's not challenging the 90th time. And so you do have to challenge yourself, do a new thing, learn a new skill, take up a musical instrument, maybe do a little language training, do some art class, listen to an interesting lecture, read a book, but don't just read the book, talk about the book in a book club so that unfortunately, I guess there's no easy road. You have to challenge yourself to some extent every day.
I think it's that, and not to stereotype, but, older people get into a habit, structure, and what you're indicating, not completely deviate from that, but slight deviations are good for change. And that change is to keep you stimulated. I mean, at the end of the day there. So
Yes,
solid.
Yeah, I think so. So sometimes older individuals you see, and the family say they're doing fine, but they're doing fine in a very small world.
In a bubble, yeah, right.
In their home, they're fine in this very confined, restricted, predictable world, and your brain wants to, in a safe way. You don't just want to head out on the Adirondacks or something like that, but on the Appalachian Trail. But in a safe way, you really want to do new things over time. You want to extend yourself a little bit, try something new. Even if you fail, it's better than not trying something new.
Solid. Want to get into the part that I mentioned, finding a cure. Where are treatments at right now? If you want to talk on that a little bit.
Sure. So the treatments, well, I'll maybe take a step back. That there are treatments that help a little bit with the symptoms, and there are treatments that may seemingly slow down the progression of the disorder. And a lot has to go into it during the way that people don't realize. So sometimes there are new developments that don't seem to make a difference to the sort of average person, like, why isn't my Alzheimer's disease better, but make a big difference to the field. And so, again, back in the 1980s, they came up with the first sort of diagnostic criteria back in 1988, and it was very clinically based. So people had to have a sort of standard presentation. They had memory loss that was progressive over time. There wasn't another cause for it. You checked some standard labs like thyroid and B vitamins and potentially a syphilis antibody. And you might do some imaging if there was a reason. And if the person didn't have strokes and all of their labs were normal, you said, well, they have memory loss. It's probably Alzheimer's. Alzheimer's is so common, it accounts for more than 2/3 of people with dementia, that even guessing, you're going to be right a lot of the time, although not all the time. But in the last few years, there's been this recognition of the linkage between the pathology of the disease, when the pathology starts, which is actually decades before people develop symptoms or even before a dementia diagnosis, it begins to build up. And so understanding that linkage and now being able to have tests that show that pathology. So you have something called PET scans, and PET scans can show the amyloid in the brain that forms the plaques. The PET scans now, although it is FDA approved, they're at this point not yet covered by insurance. There are tau scans that look at the tangles, basically. Tau is a protein that forms the tangles. We can see that. There's spinal taps. Nobody loves spinal taps. But beginning about 15 years ago, there started to be available spinal taps in which you could measure this amyloid and tau in the spinal fluid. And then within the last few years, now there are blood tests that measure forms of amyloid or tau in the blood and can make the diagnosis. So in order to get the right people, so here's the segue. So to make the clinical trials, to have the clinical trials, to then figure out new treatments, you got to get the right people in the clinical trial. So back when they started with these antibodies, they realized they started doing these PET scans. Up to 1/3 of people they thought clinically had Alzheimer's disease didn't have Alzheimer's disease.
Wow.
And so, now the trials are all trying to target, patients who clearly have this pathology.
Right.
And more recently, we're learning that there are other disorders. There's dementia that goes by the name of late, and it accumulates a protein called TDP-43. We'll leave it at that, not to be too complicated. But we see it increasingly. We thought Alzheimer's was the most common as people get older. But as people get into the 80s and 90s, this other dementia can be present too. We don't have a good way of detecting it, so it may be interfering somewhat with the clinical trials. But the bottom line is you have to recruit, you have to develop the technologies and the understanding of the disease to figure out what the diagnosis of the person is and get the right people in the clinical trial so that you can test your drug. Now, back in the early aughts, I guess, the early 2000s, drugs called the cholinesterase inhibitors came out, and these drugs block an enzyme that degrades a chemical in the brain called acetylcholine. It's an important neurotransmitter chemical. It's the amount of it and the cells that produce it are affected by the pathology of Alzheimer's disease. So that chemical is degraded in the brain and not enough of it. Initially, when they started developing this, they thought that Alzheimer's would be like Parkinson's, right? So Parkinson's, you give people dopamine, and, at least early on, they're like almost normal. If you give people dopamine, later on, they lose that. But it turned out that it was much more complicated in Alzheimer's. So increasing this chemical with medicines like donepezil, galantamine, or rivastigmine boosts the acetylcholine, and thinking is a little bit better. But it doesn't change the course of the disease. Later, they developed a drug that targets something called the NMDA receptor and helps nerve cells function a little bit better, and that was memantine that came out again, nearly 20 years ago. So those medicines help a little bit with the symptoms, but they don't seem to change the course of the disease. More recently, they have developed what are called monoclonal antibodies. So, antibodies, we all understand, target foreign substances, and you can develop these antibodies that targets certain accumulating species or types of this amyloid that really shouldn't be. We all have amyloid in our heads. Amyloid is sort of a generic term. You can have amyloid in your whole body, but there is a protein in the brain called the amyloid precursor protein. We don't quite know what it does. And for reasons that are not clear, sometimes having to do with this ApoE4 gene, but many times not, something changes in someone who's going to develop Alzheimer's, and this protein begins to accumulate. The accumulation of this protein affects this other protein called tau, which also begins to accumulate. It causes neuronal degeneration. It affects the synapses or connections between the cells. It affects the certain neurotransmitters that you lose. By losing those connections, you affect the networks of the brain, and then you'll develop the symptoms, the memory symptoms, the language symptoms, the emotional symptoms, and so on. So they develop these antibodies, and the idea being that this amyloid accumulates early. It was an early kind of the start of Alzheimer's, and if we could remove it, would that interrupt the process? So that change the course of the disease. So it clearly, these new antibodies, one being lecanemab, that's now available and FDA approved, or Leqembi, one called donanemab or Kisunla, they target different species of these amyloid proteins, help to remove it from the brain, and they do seem to mildly, by about 25 to 33% or so, slow down the progression in terms of cognitive measures or functional measures of Alzheimer's disease. They have not been tested and would not be thought to work for other types of dementia, Lewy body dementia, frontal dementia, vascular dementia, but they do seem to slightly slow down the progression. They don't improve the symptoms, but they help that progression. Now we're involved with other trials that will look at this kind of antibody again, but now directed at the tau protein, which is more closely linked to neurodegeneration. And hopefully that will make even a bigger difference to the progression of the disease. There are other trials that are looking at inflammatory markers or small molecules to improve signaling between neurons or affecting the death of neurons, and we'll see how that works. So there are quite a number of trials now.
So with that, I gotta say, it's what is the future to you look like?
I hope
no
it's
pressure.
Good. I'm getting older.
No pressure, and I know you don't know this, but truly, give us what you see the potential in the next, say, 5 to 10 years.
Yeah, I think it's exciting. I mean, compared with if you look at the treating patients, the early part of my career, when there really was very little of it. I mean, in the 90s, there was early medicine at that time, precursor to Donepezil, and it had to be taken like 4 times a day, and it was, had liver damage and stuff. So there was almost nothing available. And then for a time we were using vitamin E, which we don't really use now much in dementia. And so, as I said, when my grandfather had it, they had this Hydergine, which we don't use anymore. So there was almost nothing available. And, so now there's at least some things available that can make a little bit of difference for people. So these same antibodies that are being used once people have the symptoms, to slow the symptoms, they're now in clinical trials for people who have been found to have amyloid in the brain but don't have clinical symptoms yet. And so will giving these antibodies prevent the development of clinical symptoms? So we're doing it, going to be doing this in, this genetic group, but there are much larger trials doing it in the later onset group too. So basically, right now we have the antibodies, but they're really for people with symptoms, not, even if you knew you had the gene and you were 10 years predicted before symptoms, can't give that antibody to you yet. But now there are trials that will look at whether giving it before the symptoms develop, does that delay the symptoms or prevent the symptoms even? So those trials will come out in 2026, 2027. And that could be very exciting. If you knew before you even had symptoms, if you could prevent it, that would be huge. The tau trials, I don't think we know yet. I think there's been some promising results on them, at least early results showing that at least the antibodies, what they call in the field engaging the target, meaning they get to the tau, they remove the tau. Will that make a difference? We don't know yet. Other drugs are in trials and do seem to make I haven't even mentioned, the 100% of Alzheimer patients have cognitive problems, right? They have dementia. But like 99% have, emotional and behavioral issues too. The agitation of the disease is well known. People can develop anxiety, depression, irritability. They lose their initiative. They have apathy. So many behavioral problems. But there are now some drugs that are targeted and approved for those behavioral problems in the disease. So I think more of those will be coming out. So I guess my prediction is if the research is supported and able to continue, hopefully, that I would say in the next few years we will see more drugs come out. Will there be a cure? Well, remember the war on cancer, right? The war on cancer back in the 1970s, Nixon. So have we defeated cancer? No. I mean, there's still cancer. But we have a lot of therapies now that we didn't have before, right? From checkpoint inhibitors and lung cancer that can treat them. And some cancers, that really can be cured now, even though there's obviously still a lot of cancer. So I think Alzheimer's is like that. It's very complicated. Almost certainly there's not going to be one drug that fixes the problem. HIV, remember when it came out in the 80s and the 90s, there was a single drug that had come out at the time. And then they realized in the 90s that combinations of drugs could let people live normal lives. I mean, if it's a terrible thing now, but if you have HIV and you take this combination, your viral count is 0 or near 0, and you can live out your natural life. And so I think that's what the future is, that there are going to be more drugs, each of them picking off a piece of the puzzle, and then over time, that combination, which we'll start to study, will make a bigger and bigger difference.
Well, I hope every time I beg you and ask you to come back on the podcast in the future, it's going to be there's something new that's really making a difference. And with that being said, I want to truly thank you for being here, number one, today. More importantly, thank you for the work that you're doing. You made the comment that what people have experienced and whether it's the memory side and the emotional side. Going through this the way I have and my family did, I can't thank people like you enough for what you're doing. It's not going to fix the problems that occurred with my mom, who's no longer with us. But what we're trying to do is impact future generations, and that's really what you're doing. So from the bottom of my heart and bottom of many other people, thank you for the work that you're doing.
Well, I can't thank you enough for supporting. us. And so the support that you've given and your Lost Souls and the Alzheimer's Association, I mean, you know, all the little individual contributors to the walk and everything else just makes a huge difference. The grassroots, Us Against Alzheimer's, and all of these organizations, each, just like the drugs will pick off a piece, you guys are each picking off a piece of the disorder.
Well, thank you for that. I know I won't give out your cell phone number, but if people want to know, people want to get in touch, learn more, you've helped people that I've connected, where can they learn more about Advocate the Memory Center? If you want to share that with our audience.
Yeah, so the Advocate Memory Center is in Park Ridge, Illinois, and we have offices in Downers Grove and down south on 95th Street. The phone number for the Advocate Memory Center is 847-720-6464. You know, it is busy. We're trying to recruit new people to help us see patients. And when I haven't even talked, maybe next time, Advocate itself is very interested in brain health, and there are new programs now coming out for patients with dementia, like the GUIDE program, to provide more support for the patient and caregiver, and also focusing on that brain health and prevention, which will be coming out at Advocate in the future.
It's awesome. It looks like you've committed to potentially coming back, is what I heard there.
No, absolutely.
We're going to hear about that in the future. I want to let our audience know, obviously, there's plenty of great work that Dr. Gitelman and his team are doing. As a reminder, this is a monthly podcast. If you think you are smarter than Dr. Gitelman, I'd love to have you on the podcast. In all seriousness, I want more people who want to be here, want to talk about either direct, indirect correlation that they have with Alzheimer's or dementia, or if you support the disease from a business standpoint, please do not hesitate to reach out. Again, can't thank Dr. Gitelman enough for being here with us. Thank you all for joining us today on Remembering Together, an LMJ's Lost Souls podcast. Of course, we hope the information that was shared today, which I know it was both beneficial and impactful. As always, love your family, love your friends, and remember to cherish the time you spend with the ones you love, because at the end of the day, all we have is memories. Thank you so much for being here today.
Thank you.